and what you'll find. So I'm going to go ahead and get started. My name is Robin Nobling. I'm the Executive Director of NAMI of Davidson County. I am joined tonight by Don Liacano, who is our program coordinator, and usually the one that you're going to correspond with the most for any of our activities. We are also very happy, as we have been for years, to welcome our partners in education, and seen here tonight by Rhonda Ashley Dixon and Tracy Glasgow. They'll have some things to share with you in just a minute here. And of course, we'll have our speaker, Mr. Stewart. For the most part, if you will, unless you're asking a question, we're going to ask you to mute. If we get a lot of people on, we will try to be good if you have questions to ask with using the hand raising, the reactions there, you'll see a little hand to raise. If for some reason you're on a second screen, we get enough people to have to go to a second screen, do very politely just, give us, say hello or excuse me or something like that, so that in case we've missed you and we know that you're there. For those of you not familiar with NAMI, we are the National Alliance on Mental Illness. We are the largest national organization that supports, educates, advocates, and creates awareness on behalf of people with direct lived experience of mental health conditions and their loved ones. We have been here as the chapter in the greater Nashville area for 12 years now. And we have several services that we offer on a regular basis that can be found on our website at namidavidson.org, especially through the calendar features where you'll sign up just as you did tonight. We encourage you to explore other things on the website because there's a lot of other free services and local supports. And of course, you could always call our helpline at 615-891-4724 for any assistance, weekdays from 9 to 5. A 24-hour number we would like all of you to have is the 24-hour Tennessee Mental Health Crisis Line, which is 855-274-7471. That's 855-274-7471. And we will also try to get you the Tennessee Red Line at the end of the evening so that you also have that number, because that is our counterpart, TADIS, who serves more predominantly folks with substance use disorder. So welcome, everybody. I'm going to hand over to Rhonda Ashley. First, I want to welcome and say hello to Jessica Walker, who is ever present for our events as a representative of our Vanderbilt group. So Jess, thank you again. I know you're driving, you can't participate with your picture, but it's good to have you here. And so Rhonda, would you please introduce yourself and Tracy and tell us a little bit about what's going on there at Vanderbilt.
Absolutely. Thank you, Robin. Hey guys, I am Rhonda Ashley Dixon. I'm the Vice President for Vanderbilt Behavioral Health. And it is, for many years, has been my pleasure and my privilege to partner with Robin and the rest of the team at NAMI Davidson. We so enjoy our relationship, and we are able to help with some education events. When we were in person, we had the NAMI Vanderbilt support groups here. Those are still virtual at this point, but it's just been a wonderful relationship. And, so many times our patients and their families need to know about NAMI and they need those resources. And so we're just so appreciative to partner with the team there. So Robin, thank you for all that you guys do. Don, he's just been a welcome addition. And so we're always privileged to work with you as well. So thank you.
Thank you.
I'm going to turn it over to Tracy. I'm going to introduce you and then turn it over to Tracy Glasgow, who works with me here at Vanderbilt Behavioral Health. She is our outreach coordinator, and I know she wants to share a couple of pieces of information, so I'm going to let her do that. But we're glad you've joined tonight. If there's ever anything that we can do, please let us know. I think Some of you who are on the call know how to find me, but Robin and Don always know how to get in touch with Tracy or myself. So if there's anything that we can do to assist you guys, you or your family members, please let us know. We're always happy to do that. And Claudia Davis, I just saw your chat, and hello, it's good to see you tonight. So thank you. Tracy, you want to make a comment or two?
Yes, thank you, Rhonda, and thank you, everyone. I just wanted to mention a couple things at Vanderbilt Psychiatric Hospital, Vanderbilt Behavioral Health, related to substance use disorders. We have a couple of programs. We have our inpatient psychiatric co-occurring disorder unit for acute care. And then we also have an intensive outpatient program for co-occurring disorders for adults. So I just wanted to mention that we have those two programs available. And we also have a psychiatric assessment program, which we call our PASS program for short. And they do assessments for adults, and that number is 327-7000. And that's a great resource as well. So if we can be of any assistance, please let us know. And I will put those numbers in the chat box this evening too. So.
Great.
And Robin, if I could just say one more thing before you introduce Lisa, I just want to publicly thank Lisa for agreeing to present tonight and to share with this group on this very, very interesting topic, and one that's so timely for so many of us these days. So Lisa, thank you for joining.
So, and we are very happy to be able to introduce you to Dr. Lisa Stewart. And where this topic, we had a lot of signups for this topic. We can't wait for you to share your expertise and knowledge on here, because we know that co-occurring disorder is something that affects quite a swath of the population. And what we find at NAMI Davidson is we'll have folks that are experiencing mental health symptoms and they don't know what they are, or they're just trying to medicate their way through them, self-medicate their way through them. And unfortunately, through that journey, they may often end up with some type of substance use disorder. You are the best expert, Lisa, in what you're doing and all that you have that has brought you to Vanderbilt. And I would ask you to please, at this point, share yourself and all the good things you're going to be sharing with us tonight. Thank you.
All right, thank you. Let me, there we go. This should be visible for y'all for my PowerPoint. So again, thank y'all for having me. Lisa Stewart, I am a psychiatric nurse practitioner, and I work in the division of addiction psychiatry, also a little bit in the division of child adolescent psychiatry. My background is in counseling with children, but have recently pivoted more to the addiction side of things and found a real community and a real love of it. And very lucky to work with other experts in addiction. Like I see that our nurse case manager, Rebecca, is on this call, and recovery coach Tashley are also on this call. And so I'm not going to put y'all on the spot, but they also have great perspectives that if we want to hear anything else. All right, so to start out, let me see, pull up my objectives here. So big things I just want, hopefully I want you guys to take away, probably most importantly, sort of at the end, I touch on what I want everyone to know about addictions, even if you don't work with folks with substance use disorders, even if you are just part of the community. So that's a big takeaway, but also wanting to think about risk factors for development of a substance use disorder, defining features of a substance use disorder, including health consequences and the brain changes that can happen that sort of fall on in stages of sorts. And you'll notice I use substance use disorder and addiction both. I will talk about language at the end. Addiction and substance use, they're both accepted terms. I tend to try to use substance use disorder just because it is a little bit less stigmatized. That is what the DSM refers to, like substance use disorders, alcohol use disorder, that sort of thing. And I'm sure many of us already have know someone who has a substance use disorder, but I cannot resist a PBS NewsHour brief but spectacular. So I threw this in here. Can y'all hear this? I don't know how it works. So no, well, rats. Let me try getting this.
It's quite a little bit down.
I actually lost my mother. This was 2 years ago. She was 59 years old. Most important person in my life. I don't have a personal story per se. And I think the humanistic spirit really turned into it.
He had self-medicating with prescriptions that were left over in my medicines. My nose were gone.
If you can, Lisa, if you could make it a little louder. There we go. Maybe that'll do it.
I have it turned all the way up.
Yeah, I've had the same issue, Lisa, where playing a video, it's very low. But
Yeah, sorry. There are captions at the bottom that you can read.
Okay, very good.
As a nurse, I was coming off an amphetamine binge, and what happened was that so I lied down on the couch with my little boy. While I was asleep, I started coughing, and when I coughed, it woke me up a bit. This was filled with smoke, and the house was on fire. And in my mind, I said, "Thank God it's fire." So I coughed. Scared in my mind. So I said, "What's wrong with you?"
At its best, addiction was a comfort. It was a friend. Addiction at its worst was such a bad thing.
Okay, so I put all of your faces in the corner so I wouldn't get distracted by anyone's face. But I think that's a very powerful video to demonstrate, I think, sort of as we all know, the addiction affects everyone. If you notice, there was like a woman who talked about being a nurse, an immigrant, all sorts of folks. So I use that to segue into a discussion of sorts. I don't know if we normally have any sort of discussion during these, but so feel free to chime in. If not, I can just move right along. But I was wondering just like how people conceptualize addictions. And when we think about substance use disorders, what comes to mind? If anyone wants to chime in.
And please do, folks. I mean, I know people can get shy, but this is a great opportunity to talk about this topic. And I thought what really hit me in the video was when the gentleman said, we talk about drugs, we don't talk about people. So here's an opportunity to talk about people. And you said, how do you conceptualize addictions? I think before I was really active in this, I mean, through the parts of my life that I didn't have as much contact, I always thought of addictions as backroom, you know, somebody shooting up, you know, somebody drunk, but I didn't conceptualize nurses, teachers, postmen, the kid next door. So now I know it can be anybody.
Yeah. Anyone else? Anything else come to mind?
I agree with Robin. I think when I think about addictions, oftentimes I think of it just like destroying someone's life all of a sudden, and not about the people that are maybe living with addiction for a very long time, and that people in their community might not know about it, you know, but that can be true too. I think of the more like sort of sensationalized stuff that we see like in the media about addiction.
Absolutely, yeah.
Sometimes I like to think about it as escapism and control all at the same time. I think, you know.
Yeah. Tell me more about that. I'm just curious.
You know, sometimes, like you said, the nurse, right? It could be a really tough shift, or maybe she's dealt with, you know, too many losses in her particular section of the hospital for a very long period of time, or it's a part where there's just a lot of things and a lot of pressure that gets dealt with. So, you know, you take something to feel a little bit better to kind of give you that relief, and then all of a sudden you find that, oh, it works. So, you know, you experience it again, you take it again, you experience it again, you take it again. So they want that form of escapism. And at the same time, it's almost giving themselves a little bit of control when they're not feeling good. When they're not feeling good, that's kind of the best way that they can exert it, because they don't know any other way to feel good.
Yeah, well, and I think, Patrick, you also get to sort of, we'll get into the neurobiology of addiction. The way that the initially like use to feel good, and then the way it shifts to, like, if you think about the gentleman who was talking about how initially, how his parents were concerned when he was in withdrawal. They weren't concerned when he was using, they were concerned when he was in withdrawal. And we'll talk more about that. But so, and the big thing I just wanted to get at sort of with this discussion is what I'm sure everyone here on the NAMI call already thinks. Just sort of, we're not going to do the moral model of addiction, the, you know, failing. And I hope if anyone does have that sort of perspective on things, I hope that when we get into the neurobiology of addiction and we start talking about it more, hopefully I can change your mind. But that's the big thing. Just want us to go into this with an open mind about, not with a perspective of moral failing. that sort of thing, and an open mind about how everyone is affected by substance use disorders, sort of like Anna was saying. All right, so I did want to touch on working in psychiatry, have to touch on the diagnostic criteria. So substance use disorder, like I said, they are found in the DSM as a psychiatric or a mental health condition, psychiatric illness. And when you think about the diagnostic criteria, you can really break it down into three main buckets. If you've ever seen the DSM criteria before, they're always like a long list of things. And I'll show you the long list, but three buckets of those symptoms. First of which would be, well, it's a chronic relapsing condition that consists of loss of control. So loss of control implying like overuse of the substance. This could mean using more than intended. This could mean using when not intended, like when you're trying to stay abstinent, trying to stay sober, and going back to use. And then consequences for that use. So it's this compulsive use, even though it's causing effects to your health, to your safety, to relationships. And then craving. So craving sort of, so we can make it a third C, but it's really all physiologic changes that occur with substance use disorders. So this is, you probably heard of like tolerance, having to use more to have the same effect. Dependence, where you physiologically feel like you need it, and along with dependence, withdrawal. So when you don't have it, your body, you get very sick, and you can have a very unpleasant and sometimes fatal, in the case of like benzodiazepines or alcohol, withdrawal syndrome. So more specifically, what does this mean? So here's our laundry list of DSM, and with the severe, there's always the severity specifiers of mild, moderate, severe, depending on how many symptoms you have. And you can see on the right, I won't bore you by walking through it all, but you can see that, for instance, like wanting to cut down or stop using the substance, but not managing to do so, that would be loss of control over your use of the substance. When you're spending a lot of time using, recovering from use of substance, that's loss of control. You no longer are able to regulate your use as you used to. Or consequences. So when you have problems with a significant other, problems with friends, problems with family, that's consequences. Using when, one to think about is using again and again, even when it puts you in danger. So knowing that you have to, let's say you have to like use needles that are not clean and not sterilized and not new, and knowing that that's dangerous, but having to use in order to avoid withdrawal, and then that puts you in danger. Or getting yourself in situations where you are maybe having to like put your like safety in peril in the form of, well, I'm sure we could think of examples, and I'm hesitant to give one because I don't want to, but then there's craving, which goes along with the tolerance, the withdrawal, the dependence, just those physiologic changes that occur because your body gets used to a substance. And so you need more of it. And when you don't have it, you get sick. So in terms of what are the substances we're talking about, so I think almost all of these show up in the DSM. I think maybe like hallucinogens and inhalants, it's like other specified substance use disorder. But if you look at the DSM, you'll see that there's alcohol use disorder, sedative, hypnotic, which is like benzodiazepines, barbiturates use disorder, opioid use disorder. You can read all of them here. And they all have the same sort of like mechanisms of what happens in the brain once the actual like dependence, addiction settles in. They all follow the same pattern of neurobiology. And we're mostly going to be focusing here, like during this talk, on the ones I've circled of alcohol and opioids, because we have the most information on these. We have FDA approved medications for these, also for tobacco, but in terms of we're still focusing more on alcohol and opioids rather than tobacco use disorder, although it is a use disorder, which I'll admit I did not know when I first embarked down this path. I knew it was an addiction, but I didn't think of it as in the same way as like opioid use disorder or alcohol use disorder. It's also important to note that there are behavioral addictions like gambling, internet gaming, and these sorts of addictions, actually, when they've like done the neuroimaging and done rat studies and human studies, they again follow the same brain mechanisms. So why do we care about substance use disorders besides being good humans who care about other humans? Well, there are significant health, like physical health consequences to substance use disorders. So alcohol and substance use, I might also use drug use just because sometimes that's used interchangeably, but it's sort of the same thing as like addiction versus substance use disorder. I'll try to stick to substance. But alcohol and substance use is the 7th leading risk factor for death and disability worldwide. So when, I think it's the WHO, looks at all of the significant things that can cause a person harm, and it's pretty high up there, 7th leading risk factor, considering all the things. And so that equates to about 11% of the global burden of disease, so morbidity, like the sickness, the disability that people have, and mortality, it is related to or involved in 21.1% of all deaths, alcohol and drug use, which is exceptionally high for like those in terms of the preventable deaths. And then, so worldwide, when we think about what's the mechanism, like what about alcohol can lead to morbidity and mortality? Well, in alcohol, it's typically cirrhosis of the liver, so liver disease, motor vehicle accidents, and then cancer. And with substances, the diseases that often come with substance use disorder are, again, cirrhosis of the liver, often that's like mediated by hepatitis C, and then also HIV and specifically liver cancer. And then when we think obviously one thing that comes to mind for mortality is fatal overdoses. And most of the time overdoses involve opioids, but there's also stimulants that can cause overdose. They work in a different way sort of in the body than what an opioid overdose, how an opioid overdose works. But it's important to note that fatal overdoses involving opioids and stimulants is actually approaching the total number of alcohol-related deaths, which is to say it's increasing greatly. Also important to note, tobacco, which again, I'm not going to talk about a ton, but is actually still overwhelmingly responsible for the highest number of deaths per year. So approximately 5 times as many people die from conditions related to tobacco use as from alcohol use. So again, something I was unaware of as a newbie to substance use disorders, and in particular tobacco use. So that to say, the loved ones in your life, still be encouraging them to cut down on smoking, talk to their primary care doctor, talk to their psych specialist, whoever their healthcare provider is, about cutting down on smoking. All right, so scope of substance use. So I pulled this from SAMHSA, who closely affiliated with NAMI. Well, similar, sort of, maybe not closely affiliated, but SAMHSA does a lot of research and so they looked at from like an epidemiologic sort of large group survey. This tells us how many people have used a certain substance in their lifetime. So about 80% of people have used alcohol in their lifetime. And then who out of those has developed a use disorder in the population scheme of things? About 5.3%. So the majority of people try alcohol, very few go on to develop a use disorder. And then with marijuana, I do like to mention that one because this is a growing one that a lot of people have tried it. About half of people have tried it. Fewer have the use disorder. This data is from 2019 though, so I would be curious to, the latest data is 2020, and I didn't pull that because they admitted they had like issues with gathering that data because of the pandemic. So then with substances in particular, about half of people have tried any like substance like the ones we listed, cocaine, stimulants, opioids, and then about 3% go on to develop a use disorder. So overall, that means about 7.4% of people in our population at any given time have either alcohol use disorder, substance use disorder of any sort of substance use disorder. And the reason why that number is, you might be like, oh, well, that doesn't add up. That would be 8.3%, but that is accounting for people who have alcohol use disorder along with a substance use disorder. So that's why that total number is lower than each of those numbers separately. So about 1 in 10 people is affected by this. And here is just another visual representation, about 12 million people with alcohol use disorder, about 6 million people with a substance use, they say IDUD, illicit drug use disorder only, and then about 2.4 million of those have both. So that's overall. And in terms of like what trends we're seeing now in the year 2022, epidemiologically, we're seeing that more women are developing substance use disorders than in the past. So historically, it's been about equal, men and women, in terms of who has a substance use disorder, alcohol use disorder. But basically, the number of men with substance use disorders isn't going down, but more women have substance use disorder and alcohol use disorder than in the past. We're also seeing cannabis use disorder is on the rise, and I'm sure we could all like do a deep dive have a long discussion about what might be involved in that, with whether it's legalization, whether that's like changing norms, access. We could probably talk about it for a while. We're seeing vaping on the rise. So vaping in terms of just the like nicotine product that doesn't have the smoke. And among youth, we're seeing decreasing tobacco and alcohol use. So there's actually a dropping number of teens who are, I think the alcohol use one in particular is sort of surprising, but we are seeing increasing cannabis use among teens. And also of note, among adults, there's still overall increasing rates of alcohol consumption, even if it's falling among teens. And we're seeing increased overdoses, especially in Black and Hispanic Latinx individuals, which is also a change versus past when there's been a sort of like a stereotype with overdoses and opioid use disorder with white individuals. So diving into the neurobiology of addiction, keeping all that in mind. So basically, I'm going to talk about, and please stop me because because I knew everyone in this group was coming from different places, I did sort of like, I tried to make this overview the right amount of science-y, but then also peel it back a little bit. So just let me know if I am getting too in the weeds or if what I am saying does not make sense. Just stop me, just holler at me because I have the everyone's pictures hidden. But yeah, so we're talking about what's happening within an individual brain. There's been rodent and human studies that have looked at this. You've maybe even heard of like the rodent study. Well, I'll mention that in a second, but you've maybe heard of some of this research before. And basically, with any substance use disorder, the initial use is, like Patrick was saying, impulsive. It's, you're using it for this like sort of rapid, unplanned, just, you're not really thinking about negative consequences to self or others, doing it because it's pleasurable. But then this eventually, over time, when it develops into a substance use disorder, becomes compulsive use. So this is like perseverative, like when you're stuck on it, repetitive actions, habitual use that's excessive and inappropriate for the situation, for your life. And it's driven less by pleasure, like seeking pleasure, and more by trying to get relief from anxiety. So again, starts out as something being done because it's been positively reinforced for you. You had a pleasurable response to the stimuli, which was the substance. So your brain reinforced it. Psychologically, it was reinforced as a good thing. And that makes you more likely to do it in the future. A high is pleasurable, repeat use of substance. But over time, use becomes driven by negative reinforcement. So you are having an uncomfortable response to the absence of that stimuli. So once you do not have the substance to use, then you're reinforced, this is uncomfortable, this is a bad thing. And so you're in the future, you're less likely to be without the substance, if that makes sense. It's sort of like backwards of the other way. So you are reinforced to keep using the substance because withdrawal is uncomfortable, and you can avoid withdrawal in the future by continuing to use the substance. So 3 main stages of any addiction. The first is binge and intoxication. So using the substance and having the altered sensorium, altered experience, followed by withdrawal and negative affect. So like experiencing uncomfortable, unpleasant emotions, uncomfortable, unpleasant bodily sensations, and then followed by preoccupation, anticipation. So thinking about getting the substance, being without the substance, but still having it on your mind. And this is where craving comes in. So I'm going to show a video that hopefully can explain things a bit. Again, I'm going to go ahead and say, so he's going to talk about in here, he's going to draw a V, that's the ventral tegmental area of the brain. He's going to draw an N, that's the nucleus accumbens. Both of these structures work together with dopamine and are a part of the reward system of addiction. So more that like binge intoxication stage. He's going to show an O, that's for orbital frontal cortex. And that is involved in like motivation and steering you towards certain behaviors. It's part of the prefrontal cortex. And then he's going to show the P, he's going to draw a P for prefrontal cortex, and that is involved in planning, executive decision making. He's also going to draw an A and an H, the amygdala and the hippocampus, both of which are involved in memory. Amygdala is involved in like fight or flight response. So just a little bit of background on, because I don't know that he explains all the structures super well, but if he says amygdala, it's referring to like fight or flight and memory. He says hippocampus, it's referring to memory. Okay, so I'm going to turn it up again. I'm going to put on subtitles. Hopefully it is somewhat, hopefully y'all can hear it a little bit.
Attention and understand what's going on. Now let's talk about the movements. Again, it's far more complex, and I'm going to present a very simplified version of that. And there'll be 5 points that I focus in on in this presentation. I'll take my large mark here and describe some of these points. This point is located right at the top of our brainstem. That's known as the ventral tegmental area. Describing patients is just okay. Now, the second point is located here in the forehead. describing to a patient is that it's the gas pump. Yes. It functions like a sensor. It scans the environment in a way that it picks up on behaviors that could be of some benefit to our smile. For example, let's say running your smile from the trees and you want to grab it, you'll take notes. So the sensor will take notes. It's also because that's going to help us shape. So if our feet notice running from the tree, the sensor is going to pick up. The sensor is going to also release all this dopamine or gas. So it's our head. Safe and help spark. That's what it's taking notice. Okay. We know when I describe patients, it's including the snare. And it's our trauma motivation. So the summary of our next one, which is a function of our executive function, if you will. And this it functions as our brake. So we have our gas pedal, we have our steering wheel, right here. And we have our brake. Let's focus on our last point, which are a combination of difference. And we have kids. And I'm going to find between both structures. And I'm going to go back technology. I want to show this concept. So now let's look at the circuit and how it works. Let's take a very serious example, right? It's control. Okay. Walking out take notes. Watch your little sensor in your little finger and say, oh, chocolate, chocolate, chocolate. So it fires all this dopamine to the cause of your dopamine spike. And your head takes notice. It's going to shape our will towards picking up that piece of chocolate off the top. Next time, your kid's going to kick in and say, hey, in moderation, take it easy. So it's our brain saying in moderation. And our egg, I don't have dopamine spike in there. It basically comes off to shape our surrounding. Here's an example of chocolate here. So use a piece of bread, water, survival. Let's talk about what happens in the addicted brain. Circuit now becomes checked. This occurs for many different reasons. But let's look at what happens to the circuit. Now, example of a patient with anxiety disorder and co-occurring heroin addiction. This is an example. Heroin is a full new to use heroin. There are receptors in both your vein and your head. It has one it's a full new act. So it's going to burn our vein and our head. Now, discharge all this dopamine towards our head. Also, stimulating this is going to generate a very dopamine spike, much higher than natural ever. It's etched in our brain. Dopamine spike is not going to motivate us to stare us towards the thing more natural. And our pain initially can be something like it's a moderation or patients with stop control. So we're going to get a dopamine spike from an our patient members married. So now we can conceptualize patient with an anxiety disorder and addiction, what's going on in their brain. I also want to mention that a patient with anxiety disorder will also have a hyperactive and the heroin use exacerbate that hyperactivity within the so I mentioned that reward circuits are interconnected, but they will not occur independently. So the guys intersect the points of anxiety circuit and reward circuit. Now let's take this same circuit and let's utilize it in a way that we formulate a treatment plan. So that treatment plan for our top.
Okay. I will walk through that more because I know he is rather technical. I really like his accent. It says he's from Western Michigan University, but he sounds like he's from New York City or something. I really like his accent. But, and also I forgot to mention when he says mu, full agonist mu, that's like opioid receptors. So that's one of the receptors of opioids. So implying that when you have, because that part of the brain is stimulated by the opioid, by the heroin, it's also part of the brain where the dopamine is going to happen. I'll explain a little further. All right, so here is a visual depiction of what he was drawing that is more complicated. We're not going to walk through it, but point being that there are, if you are familiar with neuroplasticity as a concept where the brain over time, it's not fixed. It's back in the old days when we thought that like, oh, by the age of, I don't even know, I can't remember what age it was, everything is settled in your brain. Actually, we're seeing that things can change over time. So, and one of the things that can change is, in the case of a substance use disorder, there are these neuroplastic changes to your reward, stress, and executive function systems. That's what he was getting at when he was talking about ventral tegmental area and nucleus accumbens, that reward area where the dopamine is. Then he also talked about the amygdala and hippocampus. That's that stress or anti-reward system that I'll explain further. And then the prefrontal cortex, the executive functioning part of our brain that helps us make good decisions, plan, execute things. So in the case of these brain changes, you have sort of I'll hold off on that. Let's walk through binge intoxication. So this part, like I said, is the one where this is the stage of addiction where you're actually experiencing the high, the intoxication. So you have the alcohol, the substance, the intoxication produces a huge surge in dopamine and also in opioid peptides. So the opioid is that like pain relief. It does play a role in joy. Opioid and dopamine, you've probably heard before, is quote unquote, like with serotonin, the happy chemical or the pleasure chemical. And you get this huge surge, which produces the subjective experience of the high, the pleasure, the relief. But then you also have, along with this, develops in the brain incentive salience, which is a fancy way of saying that you have a learned association where something like a stimuli that was previously neutral, meant nothing to you, it becomes paired with that substance. And remember, the substance is associated with the reward neurotransmitters, the dopamine, the opioids. And then that makes the neutral stimuli pleasurable, like the substance is in its own right. So thinking about Pavlov's dog, how he became, the dog became, what was it? He salivated at the bell versus initially he only salivated at the food, but the bell became associated. So same thing, the cues, the incentive salience, this is just the term we use for it. And so this is part of the problem of what happens with addiction, and what makes addiction so terribly hard to overcome is because of the incentive salience. So examples of this are like drug paraphernalia. So like if there's syringes or spoons or anything like that, individuals who someone has used with in the past, and they come around and suddenly all of the dopamine rushes in again, just like if you were using the substance, and you feel that. I'm going to modify an example used by actually one of our recovery coaches. This wasn't quite how she used it, but for an example of incentive salience is if every time you get high, you eat Reese's cups, then Reese's cups become part of that incentive salience. They become a cue for you. So when you're out in the store and you see those Reese's cups, it makes you think about using the substance, and you even get the same dopamine like rush that you get from using the substance or a similar one, and which is, as you could imagine, makes it really challenging to overcome and recover from a substance use disorder. So this part of all that to say, binge intoxication, it's the changes that are happening in that reward circuit of the brain, the ventral tegmental area, the nucleus accumbens. And then we move after intoxication, you move into withdrawal or the negative affect stage. Negative affect meaning like emotionality. So with that, so basically this is chronic irritability, emotional pain, malaise, fatigue, dysphoria, depression, feeling down, stress, and loss of motivation for natural rewards. So over time, that reward threshold is raised because your body keeps getting all this dopamine from the substance, and your receptors, your dopamine receptors, start to change in their sensitivity to everything else in the world. And it becomes harder to experience reward for everything else in the world. It also becomes harder to experience that reward and that high that was previously there because of the changes in sensitivity to the dopamine receptors, which is where tolerance develops for the substance. Well, sort of, that's roughly how tolerance develops for a substance, is that the receptor sensitivity changes for those dopamine receptors. And so this is why the withdrawal and post-acute withdrawal, because withdrawal is not strictly in the 3 days or whatever. And in periods of abstinence, it can be so challenging emotionally in addition to physically. If you've ever encountered someone who is early in recovery and they're just struggling with feeling extremely irritable all the time, well, there's a brain chemistry reason for that. You get a huge drop in serotonin and dopamine during the initial withdrawal, prompting a lot of the symptoms of withdrawal. And you also get your anti-reward system, this is the amygdala, is elevating stress chemicals, corticosteroids, corticotropin releasing factor, all of these things that are basically stress hormones are increased during withdrawal and during abstinence. So you're feeling stressed, you're in fight or flight, really uncomfortable. And then you also have, in addition to this, the neurotransmitters that can protect against stress hormones, the ones we have that like are a buffer and help us out, become less effective in being that buffer. So you're getting, one, you have a huge drop in dopamine and serotonin. Two, you have a huge increase in stress chemicals. Three, you don't have your buffer system to help you out with that. And along with this, natural rewards become less rewarding. So because your dopamine sensitivity in those receptors has changed, because it's been so flooded with dopamine from using the substance, now other things aren't going to cause an increase in dopamine, like, or your body's not going to respond to it in the same way. So before, when you had the piece of chocolate and it gave, you know, a rush of dopamine, not in comparison to the substance, but still a rush of dopamine, that's not going to be as rewarding. Before, when you went to work and you helped someone and you got a rush of dopamine from that human connection, that's less rewarding. Before, when seeing your husband smile at you and that gave you a rush of dopamine, well, it's less rewarding because of the changes happening in your brain. And you have this loss of interest that is, again, in the brain, is the cause of it, but loss of interest in normal, like non-substance related rewards, which then leads to behaviorally, someone is going to focus in on the substance and they are going to focus in on the drug-related stimuli cue, the incentive salience, because those are the things that are still able to give that rush of dopamine. Thank you all for hanging with me as I'm going through this. We will take a break in a second. And then finally, the stage where after you no longer in withdrawal, no longer intoxicated, there's also this part where you are preoccupied. You're thinking about the substance, you're anticipating getting the substance. And this part is this stage is largely driven by the prefrontal cortex. So this is where sort of he was talking about the brake and the gas pedal as sort of like two different things. These are both part of the preoccupation and anticipation stage. And it's when when you have the changes that occur in the preoccupation anticipation stage cause deficits to decision-making, self-regulation, and behavioral inhibition. So over time, your prefrontal cortex is not as good at telling you, hey, maybe instead of getting high, let's go check in with our friend who is sober. Or maybe instead of getting high, let's go to work. This is sort of a simplification because there's also this part of like withdrawal that's part of this. But as you are having the deficits, your brake system isn't working as well. So if you see here where it says go system, stop system. So your go system, which is involved in like your, it is sort of connected to the limbic system, the amygdala, hippocampus. This is really increased and you're getting more rewarding cues from the substance. You're having more cravings and thoughts of use. So that part of the orbital frontal cortex that is increasing certain behaviors, like the impulsive negative short-term ones, that's really activated. You're going. But then your stop system, that prefrontal cortex, the more executive functioning, specifically like the dorsolateral prefrontal cortex, that is not working as well. So you're having less executive functioning, less thinking through long-term consequences. And so it's preventing you from doing the certain positive long-term planned behaviors. So that system is inhibited. And one thing, as an aside, one thing with poor executive functioning, some people have, or some researchers believe that because the prefrontal cortex and the frontal cortex in general is thrown off neurobiologically with substance use disorders. It's why behavioral treatments can be ineffective, because a lot of behavioral treatments are asking you to engage that part of the brain that, because of the substance use disorder, isn't working as well. And I think this is really interesting that early in recovery, dopamine receptors specifically, well, it doesn't matter. They have a reduced availability for binding. So they can't bind as much dopamine, which means that there is lower glucose in the frontal cortex, like less things are happening, which implies less activity in your prefrontal cortex. So even in recovery, there's less activity in that prefrontal cortex than would be expected because you are sober. So especially this is in the beginning, I will say in the beginning. And so understandably, this can lead to poor decision-making and return to use. Okay, let's take 2 minutes because I just threw a lot of neurobiology at you. And then we can check back in. But if everyone wants to take like 2 minutes, I'm gonna run to the restroom really quickly.
All right, everybody. We'll be joined again by excuse me, I said Dr. Stewart. I'm sorry, I keep doing that. I appreciate that she is, our nurse practitioners are very, very close to that. And I do appreciate her background and all that she's done. So if you're hanging in there with us on that, we'll just get you a little break and we'll come back in a minute. It's a lot of information to take in, but I think it does give an idea of the kind of the anatomy of addiction. So we'll be joining again shortly. While we're waiting, any of you that have any suggestions for us for topics you would like to see included in our education evenings, we are very much open to hearing them. In the past 6 months, we have had an evening on employment and particularly supported employment that included Mark Liverman of the Department of Mental Health, Wellbeing and Employment Division, and the folks from Goodwill Career Solutions and from American Job Services. We did one night knowing that anxiety keeps a lot of people from driving in our circle. We did one night on MTA, the Metro Transportation Authority. And so we have a lot of other things that we do share with you. So if you have any suggestions for future education nights, do please let us know. I see Lisa is back, so we'll come on back into our focus again and welcome her to continue.
All right. Okay, so thank y'all for hanging with me through all of that, because I know it's very dense and very heavy. Big takeaway I want to instill is that these are neurobiological changes. This is not a choice. This is not everything that happens with a substance use disorder, like if you have been touched personally, why are you not staying in contact with me? Why are you having to use? All of that, it can be explained from a neurobiological standpoint. So this is just in summary, but it's totally fine. Okay, so now to, I think, probably the more interesting part. So risk factors for substance use disorders. And so substance use disorders are extremely heritable. They are about 40 to 60% heritable. There's a lot of different genes that are implicated, and likely those genetic variations in genes are sort of what can contribute or predispose someone to those underlying neurobiological changes. So when we think about who is likely to develop a substance use disorder versus not, there could be a role of genes in changing your brain chemistry, and then that makes you more predisposed. So why one person tries cocaine and is fine, and another person tries cocaine but develops a substance use disorder, or a cocaine use disorder, stimulant use disorder. Another one you may be familiar with, a big risk factor, is younger age. So when a substance is first used or first drink, it's associated with an increased risk for development of that. ACEs, I think we're probably all very familiar with at this point, and well known the association there. And one important point is that for individuals with substance use disorders, PTSD is a very, very common co-occurring disorder, and it's why a trauma-informed approach is especially very important in substance use disorder care. Also, coping mechanisms. So this is especially true with alcohol use disorder versus substance use disorders, that there's been some research that folks with coping skills that aren't working as well for them, especially related to stress management, are more likely to develop an alcohol use disorder. Also, folks who perceive alcohol as being more positive and having a better impact on their mental health and functioning than maybe is totally accurate, more likely to develop alcohol use disorder. And then there's childhood and temperamental factors that can play a part. And this is especially true with substance use disorders versus alcohol use disorder. So for children with a lot of internalizing and externalizing behaviors in childhood or adolescence, they are at a higher risk. Also, for children and adolescents with high behavioral disinhibition, which is a fancy way of like saying children and adolescents who are not inhibited, that are more likely to do things, even if it's not necessarily socially acceptable, or they're more likely to break social norms and rules, to take dangerous risks, all in the pursuit of reward. The folks with children who have a lot of that are associated with early onset substance use disorders. And then just temperamental factors of impulsivity, novelty seeking, just these personality factors. And then when we think about outside of the individual, so shout out to anyone who knows Bronfenbrenner, any social work folks here, but so looking at microsystem factors of family and peer risk factors. So parental substance and alcohol use. So for individuals whose parents had higher use, even if it wasn't a full use disorder, just higher use, that has a link. Sibling and peer influences. So same thing as with parents. If with siblings are using more likely to develop a substance use disorder later in life. And then on the flip side of that, family support during childhood and adolescence, bonding and high parental monitoring is linked to lower use of substances. Macrosystem factors, so these are those community societal risk factors, such as socioeconomic status, lack of resources and social support. So for example, there's been some research that's shown that poorly built neighborhoods create risk compared to these like urban planned, well-built neighborhoods. Also, there's research that shows an association between Black neighborhoods that are more likely to have liquor stores than white neighborhoods. And then that is associated with development, having the liquor stores is associated with having higher rates of alcohol use disorder. There's cultural norms. For example, white communities are usually more liberal when it comes to alcohol use than like Latinx communities. Discrimination in and of itself is a risk factor for development of a substance use disorder. So there's an association, a correlation between in the LGBT community, the experience of discrimination and the likelihood of developing a substance use disorder. There's big societal factors, sociocultural factors of advertising, like when substances are targeted and alcohol are targeted towards a younger audience, that does make a difference. With marketing, when fruity, colorful drinks are marketed towards women, that does increase these sorts of things. Social media, ease of availability of alcohol, substances, low price, these are all sort of like market factors that can have an impact too. And I meant to say this at the beginning when I got into risk factors. These are all risk factors. They are not deterministic. If I were to talk about myself, I think that I would probably fall into many of these. When I look at it, I want to say it's not deterministic. It's not something where if you have these risk factors, it's a guarantee. It's just risk factors. All right, so pivoting to what is probably most important, or almost part of what's most important about this presentation, is for us to think about the treatment of a substance use disorder, because just being in any sort of treatment for a substance use disorder is the most important factor for a good outcome. So this isn't saying like, oh, being in X treatment versus Y, just being in treatment period is extremely helpful. And folks who are more likely to stay in treatment for longer when they receive it early in the course of the substance use disorder. And that also can help with motivation for recovery. Unfortunately, only about 1 in 6 individuals, I think I saw somewhere between, I also saw as low as 10% of individuals are able to access treatment. And that's any treatment. That's not like, saying like MOUD or saying Suboxone or going to residential treatment rehab. This is just anything at all. And that number of 1 in 6 is even lower when you consider folks who are accessing evidence-based treatment. So the treatment that we would recommend, like at Vanderbilt, it's even lower. And one important thing to note as well is that up to 60% of folks who present to any sort of healthcare facility with a substance use disorder lack insurance. So we know that for many individuals with any sort of like psychiatric illness, there's huge gaps. And for substance use disorders in particular, massive gaps in who can get treatment because of lack of insurance. So where do most people receive treatment for substance use disorders? Does anyone have a guess? I will go on because it's not important. But so most people actually get treatment at self-help groups. So this is like AA, Smart Recovery, Dharma Recovery, that sort of thing is where the majority of folks get treatment. And to a lesser degree, people in like rehab, also outpatient mental health centers, inpatient rehab. So I'm not 100% certain what SAMHSA, I pulled this from SAMHSA, but I assume this is like VPH, like what we have at VPH, like a co-occurring disorders unit. Private doctor's office, that outpatient mental health, hospital inpatient, like in an actual medical hospital, if you come in for a medical reason. That's some of the work I do, is I work on the consult service with medical hospital inpatients. Emergency room, and then prison or jail is a huge place where people can get treatment for substance use disorders unfortunately often do not, which I could go on about, but I will resist. And then also places like sober living facilities can also help support recovery. That's not reflected on here. First thing with any treatment is withdrawal stabilization. So I have a picture here of some receptors, because when you are in, hopefully with the brain, with all that brain science talk, you got the receptors are important. And in withdrawal stabilization, we need to stabilize those receptors, which will then help stabilize the whole physical experience of withdrawal, the nausea, vomiting, the tremulous, the shaking, the like headache, the feeling just awful, the risk of seizure. And this is usually when someone goes through medically supervised withdrawal. It's occurring at a residential treatment center, also known as a rehab, or at an inpatient psych facility like VPH on a co-occurring disorders unit, or in an inpatient medical hospital, like I mentioned, or an ER. Sometimes it can happen as an outpatient, depends on how much someone's been using, how much they're able to get help. But as you can imagine, it's a very uncomfortable experience, and we want to make sure people are safe. So that's why it usually ends up not being an outpatient thing. And so for opioid withdrawal, we are often going to treat with medications that I'm about to talk about, medications for opioid use disorder and supportive measures. For alcohol withdrawal, you're going to help someone by trying to stabilize. There's a certain receptor, GABA, a neurotransmitter GABA, and then the receptors associated with that. You're going to try to stabilize that with benzodiazepines. So you're like Xanax, Valium, Ativan. Typically we would do Valium, maybe Ativan if there's liver injury. And sometimes, well, it doesn't matter. I'm trying to decide, as I'm going through, I'm trying to decide what matters with what I'm telling you. And then there's also for folks who have a substance use, like a benzodiazepine use disorder, where they've been using like those same medications that I just listed as treatment for alcohol use disorder. If they've been overusing that, have developed a use disorder, then you want to stabilize that withdrawal with medications as well. And unfortunately for other substance use disorders, like if someone's been using methamphetamine, if someone's been using cocaine, cannabis, it's more like supportive measures. We don't have an FDA approved medication to help. There are medications that can help, and I can tell you about it if you are interested. One in particular that can be helpful. So what is the most effective by far treatment for opioid use disorder? I don't know if anyone knows what this one is. It is a medication that you may have heard of before called, it's this one right here, Suboxone. The generic name is buprenorphine naloxone. So buprenorphine is the most effective medication we have. It's FDA approved, and it is exceptionally helpful for folks with opioid use disorder. All of these medications that are for preventing relapse, they all lead to reduced cravings, less of that preoccupation, like that third stage of the neurobiology of addiction, less preoccupation with the substance, less incentive salience, thinking about those cues, and then that decrease the risk of relapse. With medications for opioid use disorder, MOUD, it is important to note that a racial disparity exists for access. There's multiple FDA approved medications. There's the Suboxone, buprenorphine, naloxone, methadone, buprenorphine sole product, and then long-acting naltrexone. So methadone and buprenorphine, both very helpful. But in terms of who has access, this is often shaped by legal barriers and geographic location. Methadone has a really unique way that it's prescribed. You have to go every day. But buprenorphine can be prescribed in a clinic, like any outpatient clinic. Well, not anyone, but a lot of them. And so it's often found like Suboxone clinics are often found in suburban areas versus methadone has more legal restrictions and it often ends up limited to urban areas. And in the United States, people of color tend to be more so in urban areas. So it does tend to methadone winds up being a more often utilized medication for those individuals, but methadone has a lot of sort of barriers to it that you have to go every day. So I want to point that out as well, that there's systematic racism in this prescribing or in just the medications in general. That is loaded.
Lisa, can I ask a question regarding the Suboxone?
Yes.
What's the average length of time someone is expected to be on that? What is the course of treatment in the usage of it to try to work them off of the Suboxone?
Yeah, so when the best research we have on Suboxone and how long to stay on it is for individuals who are followed for 2 years and who stayed on it for 2 years and then eventually tapered off it had the best outcomes. Folks who were on it for folks who would be on it for 3 months or 6 months, they very often return to use. So sort of the best evidence we have is 2 years, but even then that was, I think there is a study maybe that followed for 4 years and the outcomes were even better. So we don't have a perfect answer to that.
I'm sure it would vary per individual, but I wondered just if there was kind of a standard. Yeah.
And it's a very much on like an individual basis, but what we do know is that anything under a year has a definite risk for relapse, any taper under a year, because it takes so long for what Suboxone is doing in the brain and allowing a person to like regain their life and rebuild that brain chemistry and then also just rebuild their life. That's something that takes a while to happen. And so I think that's sort of theorized as why it's important to be on Suboxone for a while.
As we're starting to come up on the end of our time, if you could kind of synopsize some hopeful comments about treatment. And we certainly have information at NAMI that I would like to share also.
Yes, I am so sorry. I thought we were going until 8:30. I didn't realize we were going until 8.
Okay, and if you've got, and at least if you're prepared to 8:30, we usually go to 8, but if you're prepared to 8:30 and there are individuals
No, I will not. I will not
stay on.
I will not keep anyone that long.
Okay.
But we do have, yeah, so I will breeze through this because I thought we were going to 8:30. But okay,
so I didn't realize that.
Yeah, so there are non-pharmacologic strategies that are very helpful, very useful. We want to make sure that you treat any sort of mental health condition along with the substance use disorder. When we try, sometimes there's an urge to try to treat first the substance use disorder or first the mental illness and then go treat the other one. Doesn't work. They need to be treated simultaneously. A lot of people, about 50% of people who have a mental health condition who have a substance use disorder also have a mental health condition, usually anxiety, depression, PTSD. What everyone should know, even if you don't work in addictions, we are going for a harm reduction. We are no longer abstinence only, trying to meet people where they're at, and that involves harm reduction. So how would you approach someone with a substance use disorder? Patient-centered approach, empathetic, understanding, non-judgmental, respectful, accepting, motivational, interviewing. You maybe have heard of it before. This is meeting someone where they're at. You are focusing on helping them realize why they want to change rather than saying, this is what you should do. More specifics about that. Language we should use regarding addictions. No addict, abuser, person with substance use disorder, just like with any other mental illness, no substance abuse, substance use disorder. The Suboxone's our most helpful medication. So we're doing opioid substitution therapy. We're trying to move away from that and focus on medications for opioid use disorder, opioid agonist treatment. Rather than using clean, we're using sober abstinence, rather than using like anything with like dirty or clean, like with urine, focusing on just if it's a positive or a negative, like with a drug screen. And we care because stigma matters, right? There's less effective treatment. And also focusing on with substance use disorders, it is just like any other chronic condition. Things come up and come down. Relapse rates between substance use disorders and other chronic illnesses are about comparable. So with hypertension, asthma, these things are not, it is not just substance use disorders. That's sort of the way it's made out in the media. We'll end on this. Recovery is possible. So with all that brain changes, feels very fatalistic. And so you can visualize those brain changes on an MRI. You can see here on the far left, healthy person, red is activity. That's the dopamine firing. And so early in recovery, someone doesn't have as much red going on, not as much like glucose, the brain's feeding off of activity. But 14 months into abstinence, you can see that brain activity is returning. And our best evidence is that in 90 days, dopamine is mostly normalized in the brain, 90 days into recovery. That doesn't mean all the brain changes have happened yet, but at least the dopamine, which is the one that is driving a lot of it, is mostly normalized. And all right, I will leave on that note. I apologize, I had to rush through the end, my favorite, the best part of this talk. But if you are curious about what we're doing at Vanderbilt, here's just a swath of things. Bridge Clinic, where we're really focusing on trying to help people early in recovery, connect them with, it's a grant funded, totally free, insurance blind. We see people with wraparound social work services, all sorts of things. Okay. I apologize for taking longer than I meant to.
It is not your fault, Lisa. That it was a typo in the flyer.
Okay.
That we didn't catch. We advertised it online for 6:30 to 8, but the flyer has 8:30. So that's probably what you saw.
No worries. Okay, Claudia, you have a question.
Yeah.
Anyone who has to.
Yeah,
Please
just would you
sign
be
off.
willing to, or particularly anybody who works at Vanderbilt, if we emailed you, would you be willing to share your slides so that we could look at those end slides a little bit more?
Yeah, for sure. Yeah.
Yeah, what,
Just, yeah, anyone, if there's a good email, I could send it to.
If you want, we can collect them for you if you'd like, Lisa or Tracy, unless Tracy, you'd be willing to do that. And you're muted, Tracy.
Next minute, yes, yeah, we'd be happy to do that. And is there a way to post the slides with the recording or no?
I would think so, Don. You know what we can do is anybody that signs up for this goes on our list for information. And Don has a list of people that have signed up for this. Don, couldn't we send this out automatically to the registrants?
Yes, we can.
yeah,
Okay, all right,
that'd be great.
Yeah, if I just get the file, I'll send it to everyone who registered tonight.
there you go. There we go. Lisa, one of the things I'm curious about is how much peers figure into recovery.
Oh, that's a big part of it. And that was part that I had to skim over.
Okay, okay.
But yeah, there's so much evidence and in the research and what people will say for peer recovery support. So at Vanderbilt, we have folks, I don't know if she's still on here, Tashley, is like folks who have been through recovery themselves and have had a substance use disorder. It's now in recovery remission, whichever word you want to use, and are able to be a guiding light and a support for others who are struggling with this. And they are often the individuals who we as providers and others on the team are leaning on, because their relationships are deeper and oftentimes more authentic than we're able to, because they have the lived experience and they're able to speak to that. And it's very obviously very encouraging and positive for patients as well to see, like, oh, wow, here's this shining example of the way my life can transform.
Yeah, and thank you, Lisa. And something that NAMI Davidson does, because this is not a disease that just hits the individual like anything, it's a disease that hits the whole family. And it's something that we recognize. Co-occurring disorders is a condition that NAMI's recognize. And so we have a intensive family caregivers class coming up in August. Our 8-session intensive will be starting on the last Tuesday in August from 6:30 to 9 p.m. for 8 sessions. And it does include co-occurring disorder. It helps you to understand what is going on. It helps you to gain knowledge. And this has been terrific knowledge Lisa's shared tonight. It helps you to understand where your role ends and theirs begins. It's not your recovery, it's theirs. We want you to be a support, and we want you to learn how to take care of yourself when you love someone. So, and then TADIS, the Tennessee Association of Alcohol and Drug Abuse Services, if you are frustrated, Lisa, I think you were very, absolutely right in recognizing that it can be hard to find treatment, but there is, if you come across somebody or you are somebody that wants treatment, and the hard thing is when we know somebody comes up and says, I want treatment and I'm ready now, you hate to have them wait when they're ready, they've, got to that point. But contact TADIS and see, they've got a pretty good sense about where the beds are, and just all of us network together, to help find that. So if I can see you eager to share something, please do.
Oh, and shout out to PASS as well. So
Okay.
the psychiatric assessment services at Vanderbilt Psych Hospital. Patients who you can come in and talk. I mean, patients who are in all stages of readiness, come to PASS, you'll be evaluated, and it's a good place where you can safely, folks can have medically supervised withdrawal, also known as quote unquote detox, and then get connected to residential treatment, get connected to our Bridge clinic, that grant funded, totally insurance blind clinic that treats co-occurring folks with co-occurring disorders. So often that is a place we direct folks to, because we have a lot of individuals who come in and are receiving treatment from us and are saying, oh, I have a friend who also, wants to enter recovery. And we often direct them to PASS as like a first step to get connected.
That's great. Thank you. I did not know that the Bridge Clinic was insurance blind, as you put it. I love that description. So, and if we can, Tracy, if we can, we'll send out your email as to channel any questions through, if that's okay with you.
Yeah.
Yes.
Okay.
Oh.
All right. As we are, getting on in the evening, if anybody has I don't want to keep anyone that's still hanging on, and some of you are, and that's great. If you have a pressing question, and I don't want you to miss this opportunity. Is there anyone that has a question for Lisa before we end? And the one thing I will share with you is that we always say this at our presentations, there may be a question you have that you really don't feel like asking in front of a group. And we understand that. So that's why when Don sends out his information, look for Tracy Glasgow's email. And if you have a question that you would prefer not to ask in front of this the whole group, then you could ask it then. And so would you please join me in thanking Lisa for all the information she has given us? It was a tremendous amount. And Lisa, we know the time that goes into the research and the time and the putting that together. And we really, really appreciate that.
Yeah, I'm sorry I didn't. I feel like I buried the lead. I'm sorry I did all the neurobiology and then ran out of time for the rest of it.
I think some of that was quite helpful to people to understand, because we keep hearing it's a disease. People keep hearing this is a disease. Please understand it's a disease, but they never get told why or how. So, and I think for a lot of people that may have been the very first time they understood the biology of the disease, you know, the neurobiology of the disease, because I don't think it's rarely shared. So
yeah, I obviously find it's really important to me. So.
Well, we're glad that it fascinates you so, because it means that you're going to help the rest of us. So we thank you for that tremendously. I want to thank everybody for coming out tonight and taking the time to do that and sharing this evening with us. And I always think that when you learn things like this, when you get this kind of information, I have a feeling you'll really review it again as you get it, that you become little ambassadors for this. So, you know, Lisa's just sent us out armed. And so you're going to help other people understand that this is a disorder, a use disorder that it's not always, it gets to a point, it's not a choice all the time, which is frustrating for people that love people involved in this. It's very hard to see at times. So I thank you very much for helping us to understand it in that way. And thank you, Vanderbilt, for always being our partner in this. We love you guys for that. And Lisa, is there any final parting remark you want to make?
Suboxone is not trading one addiction for the other. If
Thank
you've
you.
ever heard that, that's
Thank
not
you.
true. That is not true at all.
All right, thank you very much. And I appreciate that. And so especially the fact that that you shared with us that if you use it less than a year, it's probably not going to be near as helpful to help change the biology of things, the practice and habituation of things, giving people something to help them get better. We do it with other conditions that they're dealing with. Why not with this too? So thank you so much.